What's going on, everybody? Welcome back to another episode of the Core Consults RX podcast. And we're back at you today. Not a credited episode, but we're doing a patient case episode.
We are. I think it's been a while since we did a patient case.
I think so, too.
Months, probably.
Plus, we didn't come up with a subject to talk about tonight and quick enough. So I was like, well, I had a pretty interesting patient case. Let's do this.
Just do a patient case that combines all sorts of subjects.
All kinds of stories. It's considered this like your review.
Yeah, right.
And also a free
practical
day,
review.
and a free day for us. But
right.
So getting things started off, we'll do a patient case. I don't think we've just checked in like in a while. How's everything going on your end, man, with work and everything?
Good. Just cruising.
Still liking it?
Yeah. My kid turns 2 in a few months.
Whew. That's crazy.
I know.
When are we gonna have him on here?
Oh, yeah,
let's get his thoughts on.
Get his 2-word. He can say thank you.
Atenolol.
He says choo-choo a lot.
Does he?
For his train,
That's
got a train set.
Yeah.
Yeah, a guy gave us like a train set basically for free. We went and picked it up. It was nice too.
Like a remote control one,
no,
or like
no.
one that you just attach
together the whole
That's
table
cool.
with the set and everything.
Sweet.
It's very nice of him.
Very cool.
Yeah. How about you?
Can't complain, man. Still trying to. It's such a difference, like with this new job that I'm doing like more critical. It's like critical care management, like ambulatory care mixed in. But because the chronic care part is there, it's a lot of documentation, way more than I'm used to. I'm not a big documenter
For like insurance purposes.
Well, just like how we have to bill for it,
right.
And like what you have to like capture as far as the claim. It's just like a lot of, and we have software that we kind of plug in the information to it, so it makes it as easy as not as easy as it probably could be, but easier than it would be if you
somebody's thought about it and tried to make it streamlined.
Yeah, lots of templates and stuff, but definitely still a learning curve for me. I'm used to just typing my own quick stuff over at the FQHC world and just
was it pretty much freehand for the most part?
Well, I mean, we could use templates and stuff, but it wasn't like I didn't have set things that I needed to doc. Yeah. I mean, it was just a lot less strict.
Yeah.
But it's all good. Yeah, enjoying it. Can't complain. My son's almost 1, which is nuts. Crazy. He's gotten 4 or 5 teeth coming in the top right now.
Really?
Mm-hmm. Ugh. They're cut through already, so he stopped the crying and stuff. But he'll keep he keeps bumping his mouth on the coffee table or something because he's trying to teeth on it and just loses his balance. And I'm like, oh, okay.
All of Nathan's, the front part of his crib is just chewed up like a like a rodent, just like
a rodent.
Even our coffee table. I was talking about our coffee table earlier.
Resale
just
value.
Huge bite marks all around the coffee table.
He just loves biting wood.
Just when he was teething, that's what he did. Just would grab and just jump down as hard as he could.
Can you imagine your teeth hurt that bad that you're I just got to chew some wood. This will make me feel way better.
Just got to bite down on something really hard.
Anything that'll make me feel better. Let me chew on wood.
Just a very satisfying feeling.
That's crazy.
Yeah.
All right, so let's jump into this patient case, and I got to figure. I guess we can put it on the website, but I'll switch over. If you guys are watching the video version, I'll switch over so you can at least read it on the screen.
Yeah.
But 57-year-old male patient, sickle cell disease, reduced ejection fraction heart failure, type 2 diabetes, dyslipidemia, hypertension, primary open-angle glaucoma, dry eye disease, constipation, GERD, and obstructive sleep apnea. Comes to your clinic to establish care. His primary concern today is the number of sickle cell crises that he's been experiencing. He's had 3 ER visits in the last 5 months. He is having significant constipation daily due to his maintenance opioid regimen. He also reports difficulty controlling his blood glucose. He's experienced 6 hypoglycemic events, and the hypoglycemia has ranged between 65 on the higher end down to as low as 42. And he's confused as to what he's doing wrong because he feels like he's trying to watch what he eats and keep pretty good track of his diet and all that. So he's a little bit frustrated with his blood sugar. He's also concerned that he's having vivid nightmares almost every night. He says that they're disturbing, but it doesn't keep him from wanting to go to sleep. And he doesn't have any sort of at least that he can remember, any kind of trauma or any thing that would indicate a PTSD workup or anything like that.
I had a nightmare last night.
Did you?
Yeah. Well, sometimes you have one and you wake up and I don't know, it's kind of jarring, I didn't want to go back to sleep.
Really?
Yeah. I did not it was unpleasant.
Yeah. It's not good.
That's why I'm commiserating with the
people. Imagine that just every night.
I know.
Well, I asked him if it's bothersome and if it's something that actually causes him anxiety. He's like, nah. He's like, they're pretty creepy dreams, but I just get over it. I was like, right on, man.
There you go.
But he also asked about an artificial tear because he's been using the Refresh Optive, which is a carboxymethylcellulose-based product, and it doesn't seem to be working anymore. And it's a little, just wants a recommendation on that. So lots to unpack. Oh, and I didn't have this in here, but just for reference, the patient does have GERD, and then as we'll get showing the meds, he's on Nexium twice a day and famotidine, and still having horrible reflux and regurgitation and bloating almost daily, and is very frustrated about that as well. So rough situation.
I'm sure his constipation isn't helpful for the bloating and that sort of thing.
For sure.
Yeah. Want me to go through some of the meds?
Yeah, go through the med list.
So there's a number of them. I'll try to group them a bit. So he has a number of blood pressure and diuretics, but losartan 100 milligrams a day, atenolol 50 milligrams a day, torsemide 20 milligrams 4 times a day, notably, metolazone 2.5 milligrams 2 times per week, and then amlodipine 5 milligrams per day. So we'll go through those and see what we can look into optimizing further, but he also has some lipid-lowering therapies, simvastatin 40 milligrams a day, fenofibrate 160 milligrams a day. He's on an interesting insulin regimen, Lantus 40 units twice daily, as well as Humalog. And the way they have the Humalog written is 5 units with meals, but only if his pre-meal blood glucose is over 150. So we'll talk about that. Metformin, ER, 500 milligrams twice a day. And then a few other miscellaneous things related to his other comorbidities. Hydroxyurea, 500 milligrams, 2 capsules daily, but he admits to being somewhat non-adherent with that. Mike mentioned the latanoprost that he uses nightly. Nexium, 40 milligrams twice a day, as well as famotidine, 40 milligrams a day. And then he's on the opioids, like Mike mentioned, OxyContin and oxycodone. And then for the constipation, he uses Miralax and bisacodyl.
Yep. You can see from the vitals here that the blood pressure today was 165 over 89. Heart rate is 82. Sodium 137. Potassium 3.6. Glucose was 253. And it was about 2 hours after he had eaten a light lunch when he had the blood drawn. EGFR was 95. Calcium 8.9. Magnesium 1.9. And lipid profile, LDL was at 99, HDL 49. The triglycerides are up a little bit at 242. And he has had an echo with an ejection fraction within the last couple months that was at 32%. And his B-type natriuretic peptide, so his BNP, was 56.2 at around the same time as his echo. His vitamin B12 level was also checked somewhat recently, and it was at 367. Hemoglobin was a 7.2, hematocrit 20.8, MCV 98.6. He did receive a blood transfusion about 2 weeks ago when he was in the ER, and so his ferritin level was 1491.6 after the infusion.
Gotcha. So there's a number of things. Of course, like we usually do, we'll talk about a couple of the primary things with a couple things that we could address at this current visit. But we're going to talk pretty holistically about what we think we can optimize over time. Most of this wouldn't happen in the short term. It would be a number of visits before we can get things optimized like we want to. Right?
Yeah. And ideally, obviously, we would want this patient seeing multiple specialists and things, and that's part of the problem is the follow-up is not always all that great.
Yeah, with specialists, at best, you're going to be seen every 6 months, but probably once a year.
And then you miss the follow-up, and it's like it sets you back that much.
Right. I had a dermatology appointment scheduled. It was my yearly follow-up. I think it was in May, so it would have been a year the previous May. And then it got canceled and rescheduled for the following November. And then I wouldn't miss any appointments. It just got canceled. Then that one got canceled, and it got rescheduled for, I think, like the following May. So we came up on it was like coming. So it's been 2 years, and then that one got canceled, and they didn't reschedule. So I called to reschedule, and then I can't be seen until like November again. So
well, how can they just cancel your appointment?
I don't know.
Like, hey, I hope you don't have. I mean, get skin cancer checked out. I try
to be like commiserate with them because my spouse is a provider, and some days she has, if Nathan is sick, whatever, she's got to cancel the clinic. So maybe, but they were being canceled like far in advance, like a month or two ahead, and then, but it wasn't like they could cancel that one and reschedule it for like the next day.
Yeah,
It was,
that's
like,
so weird.
Months and months and months down the road. I was like,
so what if you had like an emergency coming?
I know. And is like constantly looking at the spot on my leg and being like, you need to get that checked out. I'm like, I'm trying
Like,
to.
aren't you a provider? Check it out, please.
Right.
Use your diagnostic
Don't
abilities.
you know everything? You need to look at this mole.
Come on, you're a PA. You're supposed to know all about every specialty. Yeah, I'm sure that's frustrating.
Anyway,
wait that long, and so that's kind of what this person's
right. You can see where if you got started on something and
Yeah.
maybe things change, you can interact on the patient portal and that sort of thing, but it can be difficult, especially with specialists too.
Yeah.
Which is why the internal med primary care provider is kind of supposed to be there to help facilitate things and keep it all kind of together.
Yeah. Yep. All right. So when we're thinking along the lines of heart failure, since we'll start at the top of the list, I guess, of the medications.
Yeah.
I know he says chief complaint was sickle cell. We'll get to that because there's less to talk about. But Cole kind of lumped all the blood pressure and diuretic medications together. And when we're thinking about hypertension, we have our typical algorithm of wanting to utilize ACE or ARB, a calcium channel blocker, and a thiazide-like diuretic. Usually, those three medications we try to optimize first before adding on other additional classes. When the patient has concomitant heart failure, that's where things sort of shift because now the heart failure sort of takes precedence over the primary hypertension.
Right.
We do still want to control the hypertension and make sure the blood pressure is at goal of less than 130/80, but the guideline-directed medical therapy is what we are kind of focusing on when it comes to heart failure, and so we know which medications can actually prolong life in that case, and so that's what we're going for.
Right. You make sure they're on the goal doses of those meds, and then if their blood pressure is still high, you can address it from there.
Yeah. So what do you want to start with, HFrEF?
Yeah, I guess I'll, so you could talk about losartan, but I'll just mention atenolol. We've talked about atenolol many times in the past, but of course we have 3 evidence-based beta blockers that have mortality data in HFrEF long-term, and that is
The bisoprolol,
succinate, bisoprolol, and carvedilol.
Did you just totally forget all 3 of them?
I literally had them in my mind. And then
I saw your face. You're like, wait a minute. I just forgot everything.
I can't even tell you what I was about to say, but I think I was about to say like doxazosin was about to pop out of my mouth. I'm like,
no.
Why would I say the worst possible thing?
Give him worse heart failure.
Yes, give him the terrible thing.
Atenolol's not on that list? That's weird.
So atenolol's not on that list. As our old professor, Wirt likes to say, Dr. Wirt, he wouldn't give it to his dog. But yeah, so that would be.
And if you hate atenolol too, you can get this atenolol and other trash available here.
Oh, nice.
That shirt's available on our website.
Nice. So yeah, that would probably be a change that we would make at some point.
Yeah, for sure. So the losartan, the 100 milligrams is technically like the labeled max dose as far as like hypertension. However, we do know that when 50 milligrams has been compared to 150 milligrams of losartan, that the 150 milligrams was superior as far as preventing negative outcomes. And so that was the HEAL trial. So technically speaking, our target dose would be 150. Now, in a perfect world where this patient's insurance covers everything, ideally, especially since his ejection fraction is still in the 30s, ideally, instead of just an ARB kind of by itself, we would like to use sacubitril and valsartan, the Entresto combo.
Yep.
We know that compared to enalapril, it does decrease hospitalization, increases lifespan, and prevents cardiovascular mortality, and so, or at least lowers the risk of cardiovascular mortality, I should say. But better option overall. So that would be ideal if we could get him on Entresto, but if not, at least we know that we can bring that dose up of the losartan a little bit towards that target dose.
Right.
And then, like Cole said, with atenolol, we know that just in the realm of hypertension, even though it's a selective beta blocker, atenolol, that meta-analysis that you've probably heard us talk about multiple times from 2004 in Lancet, basically showing that compared to placebo, it didn't really improve outcomes or change outcomes. So it lowers blood pressure, but doesn't actually reduce the risk of cardiovascular mortality, MI, stroke, things like that. And when it comes to comparing it to other antihypertensives, then it actually has been shown to increase the risk of harm, including cardiovascular death and stroke. And so it's just not a great option overall for hypertension, let alone in heart failure when we know we have 3 evidence-based beta blockers. And like Cole said, there's the 3 to choose from, and all 3 technically are okay. But in this case, where we know that we need to bring the blood pressure down further, and we're really just replacing one of our evidence-based beta blockers with the atenolol, carvedilol would probably be the best option in this case, because it's going to have alpha and beta blocking properties. So you're getting that decrease in cardiac output from the beta blocking properties. You get the reduction in systemic vascular resistance from the alpha blocking properties. And so you're going to get overall less or more blood pressure lowering than you would with the metoprolol or bisoprolol.
Yeah, he's still floating around, like Mike said, 165 over 89 for his current blood pressure, despite his current regimen. But yeah, I'd imagine an increase in losartan switching to a different beta blocker would bring it down significantly. He's taking a fair amount of diuretics. He's obviously had heart failure for a while. So generally speaking, when somebody's a new onset heart failure, they'd probably start with Lasix, and, you know, kind of depending on how significant their fluid retention is, they would use that as needed and kind of bump up and down the dose or kind of change around how they're dosing. So the fact that he's on torsemide 4 tablets a day and metolazone 2.5 tablets 2 times a week means that he's probably been past that point for a while. So there are a couple of other evidence-based therapies for HFrEF that can be considered. Spironolactone, aldosterone antagonist could be considered, and that would drop his blood pressure significantly probably as well. And then we'll talk about it with a diabetes section too, but an SGLT2 inhibitor is another option too, right?
Yep. And so did you mention the 30-minute
I didn't talk about the dosing.
So as far as the metolazone as well, and I have read some somewhat recent literature that said that maybe this isn't as important as we, once thought it was. However, if you're trying to optimize, in like this guy's case, we're trying to limit, the electrolyte wasting and all that good stuff, it's worth a shot. But if we're giving the metolazone in order to sort of give a synergistic response, enhance the response of the loop diuretic, then we would want to give the metolazone around 30 minutes prior to the dosing of the furosemide, so that it does take longer for the metolazone to get absorbed, and then by the time the furosemide is there and the metolazone's already activated, in the distal and proximal convoluted tubule for that matter, and it's ready to shuttle some of those electrolytes back into the loop of Henle to allow the loop diuretic to work on them a little bit more. So 30 minutes prior to the loop diuretic dose, and hopefully that will give him a little bit more bang for his buck.
Right.
And I'm going to switch over to my computer screen if you're watching the video version, because this is the 2022 guidelines that we've talked about in a couple episodes. But you can see where they basically want all 5 of those classes that Cole was talking about kind of right from its stage 1. So as quickly as we can get them established on these medications and start titrating the dose up, that would be the best option, for the patient's longevity and overall well-being and all that. And so, going back to the medication list, because he's on amlodipine, we know that amlodipine doesn't really provide, any sort of like outcome benefit when it comes to the heart failure aspect. It'd be probably a good idea to swap that one out for spironolactone, like Cole was starting to allude to, and then the SGLT2 inhibitor may end up helping with both the diuresis aspect and from his blood sugar as well. And his kidneys are good now, but with sickle cell disease and all that, we do still want to protect the kidneys and whatnot as well. So SGLT2 inhibitor might come in clutch in this case.
I would think so. And while amlodipine isn't like contraindicated in heart failure, like you wouldn't want to use other calcium channel blockers, like non-dihydrofuranate calcium channel blockers. Especially if his blood pressure wasn't as high as it was and he was having trouble tolerating the gold doses of the other medications, which he may once we get him on all of those. You definitely wouldn't want amlodipine on board because we don't have the outcome data that we do with the other ones.
And I think it was the PRAISE 2 trial that showed that it doesn't improve outcomes, but it also doesn't improve or doesn't cause harm, like Cole was saying. So you'd save amlodipine for a case of you have all of the evidence-based medications on board, optimize the dose as much as they can stand, and then the blood pressure is still high, then you could add on amlodipine if you really needed to.
Which, like we talked about before, is addressing the primary hypertension after you've addressed the HFrEF.
Right.
Yeah.
So that would be
it's a lot of changes.
It's a lot of changes, and that's just the heart failure.
That's just the heart failure.
So that's why Cole said at the beginning, like, this would definitely not be something we could do in one visit. And I mean, there's just no way, because there'd be too much risk for side effect. This would be a long process to get this patient's regimen fixed.
Yeah.
So we did a couple things at first visit, and then it should be a quick follow-up to make sure we can keep on track.
Right.
But so, the hypertensive meds have kind of, at least we got a game plan going. It's going to take a little bit to optimize those. But what do you want to look at next?
Not necessarily the highest priority, even though his lipids are good, but just because it's next on the list, we could talk about the lipid lowering therapies. So he's on simvastatin 40 milligrams, fenofibrate 160 milligrams daily. So there's a number of things we can consider here. For one, amlodipine and simvastatin interact, raising the simvastatin levels and increasing risk for side effects and that sort of thing. So we talked about how we probably will take him off of amlodipine, but still not ideal there. Maybe a better option is to consider a high intensity statin. So he doesn't have a history of ASCVD from what I can tell, right?
I think his ASCVD risk is high enough, though, that would warrant.
And I didn't calculate an ASCVD risk on him, but it surely is very high considering all his comorbidities and his heart failure risk factors, all that sort of thing. So high intensity statin would probably be reasonable for him. And likely at some point he was started on fenofibrate because his triglycerides were high. There's a couple of things that Mike was kind of talking about before on that, but one is that his volatile sugars, especially sugars being high, could be related to his triglycerides being high. Additionally, if we had him on a high-intensity statin, it might bring his triglycerides down on its own, and we wouldn't have to have fenofibrate on board necessarily.
Especially if we're going to shoot for the ADA's like LDL goal recommendations that have been updated recently.
Yeah.
I mean, this patient is basically going to be at least less than 70, if not high enough risk to be less than 55 for his LDL. And I think it was 90 something, 99. So definitely some room to move, and stopping the fenofibrate. There was I think it was the Accord lipid trial where they added, I believe it was fenofibrate to simvastatin, and they didn't improve outcomes. So we already know that combo, unless the triglycerides are above at least 500, sometimes some resources say 1,000.
Yeah.
Then we're not really helping too much of fenofibrate. So. Right. Like Cole said, Atorva, we could jump right to 80 really if we needed to. If we're worried about the dose, or him being worried about the dose going up so much, then 40, because at least even though it's a high intensity versus moderate, aesthetically it looks the same.
Right.
And then if we still needed some lipid lowering on top of that, or some LDL lowering, triglyceride lowering, we could always add ezetimibe if we need to get the LDL a little bit lower. If the LDL is good, the statin's being tolerated, and the triglycerides are the only thing that's elevated still, if it's between 150 and 500, we know that there's data with icosapent-ethyl, which is a purified form of fish oil from that Reduce-It trial, so we could add that potentially. It's like the only fish oil study that's showed positive outcomes. So it's not Lavazza or any of the other omega-3 generic brands. It's got to be Visipa, which is icosapent-ethyl specifically.
Right.
So that would be an option. We now have outcome data with bempedoic acid, Nexletol. So that's an option.
Yeah.
PCSK9 inhibitors. We got a lot of things to choose from that are better than fenofibrate.
Yes,
so,
for sure. I don't know if this guy would fall under the PCSK9 category.
Probably not.
Given that his LDL seems to be responding pretty well to the statin, it just could use a little more lowering. But if he was secondary prevention, or if his LDL was remaining high despite high intensity statin, he might pop in there for that.
Plus, we don't know how high those simvastatin concentrations were with that amlodipine.
That's true.
They might have been like taking Simva 120.
Yeah, right.
It's responding, but I'm real achy.
Yeah, I know. It's responding, but I literally can't stand up.
If you've ever gone to the restroom, have you ever had like urine that looks like Coca-Cola? That's normal, right?
That means you've been drinking. I've just been drinking too much Coke.
I've been drinking too much Coca-Cola.
Too much Coke Zero.
Yeah, it's why my A1C's messed up. All right, so we got a plan for the statins.
Yeah. And obviously not high at all on the priority list at the moment, probably like fourth.
Nonsense. Keep the atenolol, change the statin. Right. But definitely a plan for that one. And actually, one of the things we did end up changing, because we were trying to simplify the regimen, and so Simva and Pheno combined to give a Atorva 40 is what we ended up going with.
I think as far as changes go, even if it's an additional change, removing something or simplifying something is something that you can do a lot of that within a single visit. It's just the adding on that that you have to do over
People
multiple
don't
visits.
like all the adding on.
Yeah,
they
they don't like
like
adding
taking.
on.
They're all about taking away.
But there's
for the most
there's a
part.
lot of providers who don't like adding a lot of things on at the
Yeah.
same time either, because if there's a side effect or if there's an issue, we don't know which one it was.
Right,
Maybe
100% for sure. And so that takes us to diabetes, which is something that's been frustrating him, and he's a little bit
It's higher on the priority list.
and he's just confused as to why he's putting so much time and effort into his diet and all that, but not getting the results, having hypoglycemia, definitely concerned about that. And the time of day that the hypoglycemia is happening doesn't seem to be like predictable. He's been trying to eat steady meals. He doesn't skip meals. And so the first thing that kind of struck me was the fact that he's on 2 doses of basal insulin a day plus 3 doses potentially of prandial insulin.
Yep.
And then metformin, which is good. We know that metformin, if a patient's on insulin, we add metformin, that decreases the total daily
Insulin
requirement of insulin burden, and it also can cut down on major cardiovascular events. It can cut down on the weight gain you see from the insulin. Long term, it can even lower. It obviously helps your body to utilize that exogenous insulin better, so it makes you more insulin sensitive. So,
what was the new guideline that didn't say metformin for everybody?
ADA.
That was ADA.
Mm-hmm.
Yeah.
So, really, this patient should have been on an SGLT2 inhibitor first off, and then I would have wanted to go with a GLP-1 before jumping to prandial insulin.
Yeah.
But
which I guess historically, were you able to see if he had done any of that stuff?
No,
before?
It was, and I don't know if they were just worried about insurance covering it or what the case was. But the first thing that caught my mind though was the basal dose, because this patient is basically getting 40 units twice a day of basal, and then like maybe 10 units total of prandial insulin.
Yeah.
So that's not a great ratio for someone who's been established on insulin for a while. A1C is not quite controlled, and because the patient is having hypoglycemia, that obviously raises concerns as well.
His glucose today was 253.
Yeah, and I don't even think I included the A1C, but it was a 8.5 basically. And so with that being said, I think we talked about over basalization sometime
at least once.
Yeah. So the thought of like just continuously going up on basal insulin is a little bit skewed. Like the more you go up on the basal insulin, the higher you go up, the less impact those additional units will make, because you eventually get like this plateau effect to where eventually you can get to the point where you're causing over basalization, and you could potentially just worsen the patient's overall blood glucose control because you're just giving too much basal insulin. It's something that I feel like ever since I started like thinking along those lines of overbasalization after I talked to the endocrinologist that one time a while ago, and I feel like I've noticed it so much now that it happens all the time.
Yeah. Well, if you think about how we learn
insulin just keep titrating up.
Just, blood sugar still high?
Yeah.
Keep titrating.
Yeah, we don't know.
There's a calculation. Calculation. Keep titrating.
Yeah.
It doesn't come up.
Yeah.
But if you think, it's not really natural. It doesn't follow a natural insulin release rhythm that the body gives, just to have a whole bunch of basal insulin going all the time, and not the spikes with like food and glucose and that sort of thing. So it does make sense, but it's not something that I was ever really talked to about.
For sure. And I switched over, if you go watching the video version, so you can see this is this excerpt from the ADA guidelines that talks about over basalization. So they're basically saying that if the basal dose is more than 0.5 units per kilogram per day, if they're having elevated bedtime or morning and or post or preprandial differential hypoglycemia or high variability, which this patient is having a lot of those things, they may be at risk for overbasalization. So I calculated the units per kilogram per day, and it was basically 1 unit per kilogram per day. Nice. So it's twice as much. And 0.5 is being a little generous too, because I've seen some resources that say 0.3 and higher is overbasalization. So he's getting way too much basal insulin, way, way, way too much, and not enough prandial coverage, or at least not, using it properly. Right. So with the first thing I would do is back down, way down on the basal dose. Probably if there's on 40 units twice a day, I would probably, you could realistically get away with probably like 25 units twice a day at first, and then maybe even less.
Yeah.
In fact, the one endocrinologist that first kind of like was talking to me about this in depth was like, if they're on 80, 90 units of Lantus, I'll just cut it in half, like right away, and like they'll get better.
Yeah.
And so I thought that was kind of interesting, but I haven't had the stomach to do just to cut it in half yet. But
you'd have to be like, so you might have to use a lot more Humalog for the next few days.
I really hope I did the math right on this. This endocrinologist seemed like a real straight shooter. But, that would be the first thing I would address is back that down. And then as long as there's no contraindication to him having a GLP-1, I would probably try to utilize that over the basal or the prandial insulin anyway.
Yeah. Maybe his triglycerides were high in the past and somebody got nervous about that.
Pancreatitis or something.
But I mean, along with the steps we've talked about, I don't think we could probably take away that concern.
Yeah. With the GERD, the only thing I would be worried about a little bit is if there's any sort of like gastroparesis happening. Diabetes has been not crazy uncontrolled, but he's had diabetes for a while, so that could be an issue. And also, if there's any sort of like concern, I guess, if they're not producing insulin anymore, there's always that risk of, I did look and see if there's a C-peptide or any of the autoantibodies like the GAD65 or IA2 islet autoantibodies, and didn't see any of that stuff. So I think it was really just a matter of, and he couldn't tell me if they'd ever, he'd never heard of like the once a week options or anything. So decreasing the basal dose, you can keep the metformin, but really if one of the options to get rid of the metformin would make him more willing to use the SGLT2 inhibitor or something like that, I would definitely swap them out if necessary.
It's more important.
Metformin, is not what I'm worried about. And then I would try to use the GLP-1 or the tirzepatide, the GLP-GIP, if that's possible, which probably would have to use the GLP-1 first for insurance purposes.
Right.
But just really watching the basal dose in patients. If they're only on basal insulin, you still don't want to over basalize the patient. The other thing is with the way that his dosing is set up for the prandial, dose, per meal. If the patient's blood sugar is above 150 going into the meal, then he takes his like base, set of units for the meal. That's going to cover the meal itself, but that's not going to correct his blood sugar that's already high. Right. So really it should be his set, units for the meal plus a sliding scale, and that maybe goes up one additional unit for every 50 milligrams per deciliter of blood sugar that it is above, what we would consider appropriate fasting blood sugar. That would be a way of doing the prandial insulin. But I think that's a lot of moving parts. That would be a lot easier if we just did GIP or GLP.
Yes.
And called it a day.
Right. Nothing necessarily wrong with prandial insulin. But
no.
It's a strange thing. I mean, I imagine the reasoning is to lower risk of hypoglycemia, which he has had 6 events, being pretty low.
Lives by himself.
So, I mean, there's concerns there, but it seems like the better option would be to try to attack the postprandial with the GLP.
Yeah. And if we had to use insulin in this patient, like in a more strict insulin regimen, then getting him on a continuous glucose monitor that has like alarm systems and stuff. Yeah. Did I tell you we did some diabetes training thing at work, and they gave us Libres to put on. So I was wearing mine, and me and Jen were trying to see whose blood sugar was better. But then I forgot to like turn it off when I went to sleep at night, and so my blood sugar hit like 68, 69, which I felt fine. I was sleeping, and it was going off, and I was like getting so mad because I could not tell what the stupid alarm was, and I was like trying to make it. I thought it was my phone alarm, and so I'd hit it in like every 10 minutes, and finally I was so mad at it. I was just making a joke because I was just trying to, because Jen was frustrated because we couldn't figure out why I was going off, and I was like, oh no. She's like, what? I said, I'm hypoglycemic. I was like, do something. She's like, it is too early for
which
this.
You can customize them too, right?
Yeah.
Yeah, we have I know somebody who said it to be kind of dangerously low, like kind of concerning.
Do not tell me unless it's 30.
Right. She was like,
if it goes low, don't tell me.
I don't know. Yeah, you can definitely do it to where to what suits you, I suppose.
Yeah.
But still, so they would call that like what, an unaware hypoglycemic event if it was below the threshold. And
plus, if we're going to switch into carvedilol, that's going to potentially mask a lot of those symptoms of hypoglycemia.
That's true. So it is a very helpful thing, and I think I saw that there's a new version of the freestyle coming out.
3. I guess the 4 is on its way too, apparently, but the 3
I don't know what they're really going to change. But
the 3, I think, is actually a lot smaller and easier to use. But the Dexcom G7 also came out, and now you don't have to have the
G7.
The 3 different pieces. It's back to 2 pieces like the Libre, and I think it goes in the arm again too. Because this G6 I think stuck in the stomach, which seemed a little uncomfortable.
Yeah, so I mean, and you can get those approved with, volatile blood sugars and stuff these days.
If you have a patient on this insulin regimen, even if they're Medicare like this patient was, you can, if you go, there's a full sheet on Dexcom's website that's the Medicare approval sheet that you can utilize.
Yeah.
So,
and you might run into high cost shares or something like that with Medicare plans, but it's definitely something to pursue.
There's ways to do it.
Yeah.
It's unless you're like in a retail setting, it's going to be a lot harder. You really need to be in a clinic setting to get all the paperwork done.
Have some support staff, or you can do it yourself. Then, it's doable.
I am my support staff. Just kidding. That's not true. All right. So we'll save the sickle cell for last, but the patient's also on a crazy amount of acid reducing agents.
Yes.
Esomeprazole 40 milligrams twice a day, famotidine 40 milligrams daily, still having tons of reflux. So asked him how he was taking the Nexium, taking the evening dose at bedtime, going to sleep, taking the morning dose first thing in the morning, doesn't eat breakfast until about 2 or 3 hours later.
It's basically peeing it all out.
Basically not getting any of the dose. So if you remember, yes, on the box, on the OTC product for Nexium, it says 24-hour relief and all that good stuff. That's partly true. It's true in a way, from a certain point of view. And basically saying that if the medication gets to where it needs to go, in other words, it gets to the ATPase pump that's pumping that acid into the stomach and making it more of an acidic environment, if it gets there, it shuts that pump off, then yes, it takes your body a whole 24 hours in order to make new pumps. If the pump is not turned on and activated to actually start releasing that acid, the PPI is not able to bind to it nearly as, with the same affinity. And so if the patient doesn't eat for 3 hours after, or takes it at bedtime, doesn't eat till the morning, the half-life of a PPI is only an hour. And so, the medication is, for the most part, gone out of the system by the time he's actually eating a meal. And so not really getting much benefit out of the PPI despite taking it twice a day.
Generally speaking, how do you feel about the twice a day thing? I try to be more open to it and say like, well, maybe it could capture some pumps that weren't captured with the first dose. But
I think if there's like any issue, obviously if there's been an ulcer, like you're healing an H. pylori infection, something like that, any kind of like peptic ulcer, you're going to do twice a day for just mucosal healing. Yeah. I would say usually in most cases like this one, doing it twice a day is probably unnecessary, because if you switch and take the medication correctly 30 minutes to an hour before a full meal, you probably wouldn't need.
And then what if they said like they did that, it's still not working?
Then I don't know. I'm not one of the people that wants to die on the hill of PPIs. Yeah. Like there's some people that are like that's their life's mission of like getting people off PPIs. Like I'm like you can keep smoking, but you got to get off this PPI.
Right. I remember there was a pharmacist who every time that I worked with a little bit, that every time someone would pick up a PPI, he'd say, you know that's going to kill you, right? Yeah.
It's like, hey, maybe you shouldn't say that to every customer. But I don't know. I know there's risks associated with them, but I feel like, if someone's having bad enough heartburn to where it's just decreasing their quality of life, it needs to be a discussion with them. Right. And they're over the counter for, right. If you're not going to prescribe it to them, they can just go get it anyway. Get it. So, and then with famotidine, it does have, better PRN type usage, because it's gonna work pretty quickly and give him some relief, but he's still having to use this every day, which if the esomeprazole was working appropriately, technically speaking, the famotidine probably wouldn't be much benefit at that point, because it's kind of eventually targeting, granted it's targeting further up the path, if you will, the signal path, but it's eventually getting to that ATPase pump anyway. And so if it's already been shut down, then famotidine is not really helping all that much. Right. Now, in this case, the famotidine is probably the only thing that's really really helping, because the esomeprazole dose is not there, except there is really a high prevalence of tachyphylaxis with H2 blockers. And so at this point, he's been on the famotidine for years. So I would bet that there's probably not getting much benefit. Plus, started mentioning that he's having neuropathy at this point, and he's attributing it to his diabetes, and even was saying that it's getting bad enough to where he was going to ask about something like gabapentin or what have you. Last time they checked a B12 level, which was 6-something months ago, it was in the normal range, but on the lower side of normal. Metformin we know can decrease intrinsic factor, which can decrease the absorption of B12. We know that hydroxyurea can decrease B12. We know that esomeprazole can decrease vitamin B12. Famotidine to some extent can as well. And so he's got a lot of medications working against him when it comes to vitamin B12 absorption. And so it would probably be a good idea, especially if he's having, neuropathy type symptoms. That's one of the ways that low B12 levels will kind of manifest from a symptom standpoint. And so getting sublingual B12 supplementation would probably be a good option.
Yeah. And
making sure it's sublingual, because if you just take an oral tablet, you're in the same problems. But so as far as the PPI goes, the switch that we made was actually stopping the esomeprazole altogether and giving Dexilant. Dexlansoprazole is the only PPI that doesn't have to be timed in relation to the meal. So it can bind to the pumps regardless of whether they're active or inactive. So I will say I used to think that Dexilant was like a big kind of just a Me Too drug that was like super expensive, but I have had so much success with switching people off traditional PPIs now over to Dexilant. It's like not even funny.
Yeah.
So I'm like, okay, I'm a Dexilant.
It's great.
I'm a Dexilant fan.
GERD is one of those things that affects people's quality of life pretty significantly.
For sure.
That it's like one of those things that everybody has, so you discount it a bit. But like, man, it is, as I get older and experience acid reflux a little more, it's like, God, this is terrible.
Well, then you tell people, just stop eating the foods you like.
Right.
It's like, okay, well. Yeah. I'm not going to do that. Right. So I'm going to have chicken wings still, and I'm going to be miserable for 2 days.
I'm going to eat my spicy tacos.
Yeah.
And
so now I got Dexilant in my corner.
Right.
Ready to go. All right. So you mentioned the opioids that the patient's taking for pain control. On a pretty strict opioid regimen with Oxycontin and oxycodone daily. But we know that besides, the other concerns we have with opioids long term and having Narcan available and all that good stuff, it also can cause really bad constipation. So opioid induced constipation.
Do you know if his opioids were related to like some certain pain? Or
it was the sickle cell.
Okay.
Yeah, because it's constant.
Yeah.
And he'll get more like Dilaudid in some of these IVs if he's going through a crisis, but he's on oral meds at home.
Right. So this is different than a regular chronic pain situation that we might be talking about.
I told him just take CBD and get over it. Right. I'm just kidding. No, but in this case, it is extremely painful for these patients. So they are taking opioids chronically, which means they're having constipation chronically. So there are a few different options. There's like the Movantik and some of the traditional medications that are indicated for opioid induced constipation, where you're blocking the opioid receptors in the GI tract, but not the others in the CNS or whatnot. And so those are potentially, we can go that route. I am actually a big fan of Linzess. I know we've talked about that a lot with IBS, but Linzess is not technically approved for opioid-induced constipation. I believe Amitiza does not have that indication, but Linzess doesn't, have that indication, but it is oftentimes used off-label, and it has good data, specifically in opioid-induced constipation. So you still want to have a patient start off with usually stool softeners and some kind of stimulant laxative like bisacodyl. And then this patient's taking Miralax on top of it. And so at this point, they've been doing it, twice a day, every day for months and months, and only having a bowel movement like once every 4 days. So at this point, Linzess would be my next option, because we want them to get regular, and then that's 2 more meds we could potentially take off, and they're not having to drink that liquid every day.
Right.
So it's again, it's as long as cost. I'm fortunate because I work with a clinic that is also associated with a 340B pharmacy, and Linzess is one that you can get fairly cheap with 340B. So I'm gotten a little spoiled with that, but there's patient assistance programs and different options and things like that to get it. And I feel like a lot of insurance companies do cover it now, as long as you've tried some of the other things.
If it's off-label, it might be a little more difficult.
That's true. Yeah. But just say they have constipation. Just lie on the ICD-10 codes. That's the way to do that.
Fraud is definitely the best way to do it.
Like a crime.
Right, like doing illegal things.
Like doing illegal things, then putting it on your podcast, and then getting arrested on pod. Could you imagine the SWAT team just storms my house for inappropriate ICD-10 codes?
You used the wrong ICD-10.
You said he was level 2 obesity. He's level 3.
We're the Medicare police.
gosh, that'd be scary.
Yeah. That actually is kind of scary.
Yeah.
We have to take those fraud, waste, and abuse things every year, you know? And, yeah, the penalties and fines are pretty significant.
Oh, they're yeah. It's like we might put you in jail for
Like a long
25
time.
years.
I know.
It's like I could get less jail time if I just robbed a bank.
Right. Like you
$500,000.
You submit the wrong ICD-10 codes to a commercial insurance, they might just take the money back. You do it to Medicare, you're going to jail.
Yeah, I like the ones that are like you can pay $10,000 fines or up to 4 years in jail. I will pay the $10,000.
I'll take out a
4
loan.
years. That is, I don't know what the dollar an hour ratio is for jail, but that's got to be.
It's not good.
I'm working overtime. All right, so finishing up, he's on the latanoprost for the glaucoma. Intraocular pressure is stabilized, all that's good. But he mentioned the fact that he is needing a new artificial tear because the Refresh Optive is no longer working. I think we did a dry eye episode not too long ago, right?
We did glaucoma.
Yeah, but we did dry eye too, I thought.
We might have.
Maybe? I don't know. I know we've done one at some point. I thought we did an episode that was like, you know.
Every time I think something was recent, I look back and it was like 4 years
that's true.
ago.
I have no concept of when we've done anything. But I'll switch back over to my computer so you can kind of see if the picture will come up.
Blank cool screen.
Yeah, that was a cool background. But this diagram, this was in a meta-analysis that was put together, basically comparing all the different artificial drops that are options available over the counter, because there's a million of them that you can just go down the ophthalmic aisle at any pharmacy and you realize there's so many choices. And so this just kind of gives you some ideas of which products and which active ingredients are kind of like in their hierarchy of efficacy, so to speak. And so you can see that Refresh Optive is on the beginner side of this algorithm. And so if they're having refractory symptoms, and really this is not saying you have to start over at the starting point here on this algorithm and then work your way around the picture. Basically just it's giving you a reference of what we would expect to be a stronger, more potent or more efficacious drop, so that if the patient is on something like hyaluronic acid, that you don't backtrack and give them Refresh Optive, since they're kind of in the same category. You'd escalate therapy. So because he's on the Refresh Optive, which is one of the starting options for patients who've never tried anything, if he's having refractory symptoms, then escalating to like Sustain Ultra, which is a polyethylene glycol 400 based product, or a Soothe, which is a propylene glycol glycerin combo. Did I say suppository? I meant eye drop. I don't know why it's suppository.
I mean,
I guess you could use it like that. It's not going to probably...
You could probably use the eye drop where the suppository goes, but the suppository where the eye drop goes...
It's not going to dissolve very well.
That might be a problem.
You're going to have blurred vision. But so you could escalate from there. And there's definitely nothing wrong with using the artificial tears, and you can even go up to where you're using the gel or even the ointment. I will say the latanoprost, and it depends on how long he may have just had chronic dry eyes for a long period of time, but the latanoprost, the formulation's been around for a long time. It's got a generic version. It does have a preservative in it, which we talked about when we covered glaucoma, that benzalkonium chloride, the BAC. And basically, the longer you use that, it can disrupt the surface tension in the eye and worsen dry eye disease over time. And so it's something that if the patient's going to be on this long term, which in this glaucoma you are, using a preservative-free option would be ideal if possible. And latanoprost, which I feel like we mentioned this, but latanoprost does actually have a new, somewhat new, it's not really not new anymore, but like 6 months ago got approved for a preservative-free formulation under the name Iyuzeh. I believe it's Iyuzeh. Iyuzeh.
We use it. He use it.
Whatever.
We all use it.
Yeah, and so it's the first preservative-free formulation of latanoprost. They also have travoprost that it has a different alternative to BAC that might be a little bit less irritating in the eyes, and then the talfoprost is the one that comes as the Zyoptan as a brand name. It comes as a single-use vial, so that would be another potential option. Now, if he has other signs and symptoms of more systemic autoimmune type situation, like Sjogren's syndrome or something like that, then maybe we need to evaluate to see if Restasis or something is a better option. But it could be just from having the preservative day in,
Could be.
day out. So
Could
just something to at least have in the back of your mind. We kind of just threw it in there. We like to call that the show off recommendation. just a little nugget.
Have you heard of
there.
benzalkonium chloride?
Yeah, well, let me tell you all about it.
I'll tell you about
Strap in. You're about to be bored to death.
So is the last thing the sickle cell?
Yeah. So the patient is already on hydroxyurea. We know that that's kind of ideally, the first line option for preventing the sickle cell crises. And the issue is the adherence. It can cause a lot of GI issues. Could be, because he's got all of the issues with constipation and having the GERD and nausea sometimes. And it could definitely be something that he's just kind of not wanting to take it because of the GI issues or other side effects. In this case, when we talked more about it, he's like, I don't know, just because it's got so many, it could have so many negative effects on the body as far as, immunosuppressive and, all those types of things. He's like, I don't want putting like poison in my body. So we talked about how it, is actually decreasing all the long-term complications of sickle cell, including those pain crises, because that was one of the things he brought up of he doesn't understand why he's having them so often. And really, then after we started talking about that, he's like, well, actually my primary physician that handles my sickle cell was actually wanting me to go to 3 capsules a day, and I had refused. And I'm like, and then how soon after that did you have a crisis? And he was like, within the same month. And I was like, no. Yeah. So, we talked along about that, and he said he's going to try to be more adherent and see how it goes. But, the other issue is having to get transfusions, iron infusions, things like that with the hemoglobin dropping so low. The hydroxyurea will definitely help reduce the risk of sickle cell anemia. But there's also some potentially other options we could at least look at. From a strictly anemia standpoint, we have the oxybrita, which is the voxelotor, and it was approved in 2019, but it is basically there to add on to hydroxyurea to reduce the risk of anemia or hemolysis. It doesn't actually, at least from a statistical standpoint, it doesn't reduce the risk of acute pain crises, but it does reduce the risk of anemia and hemolysis, which this patient is dealing with and has been dealing with for a while. So that would be a potential add-on option, which actually I brought up, and they're like, yeah, actually they wanted me to take that one, but I didn't want to add it. And I was like, nailed it. Even though the patient still didn't want to take it, I was like, well, at least I knew what to do.
You knew what it was.
Because I'm new to this whole sickle cell thing. But, that would be an option for the anemia aspect. Now, if the hydroxyurea has been, maxed out as far as what the patient can tolerate and, if we safely can administer to them, then we also do have a couple other options potentially. We could add on the L-glutamine, the Indari. That's been shown to, reduce the risk of sickle cell crises and whatnot and improve, outcomes, but it can also cause constipation and other GI issues. So there's that. And then which we don't currently have it set up at our practice for adults, but if we get that eventually, we can do the infusions as well with the crizanlizumab is another potential add-on or monotherapy instead of hydroxyurea for patients who can't tolerate it.
What was his hesitancy about hydroxyurea again?
He just because it's, if you read through all the monitoring parameters and, it's not like a mild drug. I think it was just looking at the box warning. I
just thought it was interesting that I guess he didn't really express non-adherence with anything but that.
Yeah, it was just because that was the one in particular that I'm like, I really honed in on that because I've just, the few sickle cell patients that I've seen so far this new gig, I feel like have been really resistant to hydroxyurea. So I just asked a little bit more
to figure out kind of why and their thinking around it. Yeah.
So, but I think it has to do with a lot of, but plus it's like, when they're talking to other people that they know that have tried it or, then they get a bunch of information and it's usually negative.
And I would think a great motivator would be not having an acute, which I guess it doesn't. Well, I guess it does some, but the pain crises I feel like would be like a motivator. It's not like hypertension or something that's a little more silent. Like it's very practical. And
hydroxyurea is one of the only ones that really decreases those occurrence of pain, those pain crises by a pretty significant, rate. Yeah. So definitely encourage them to go that. And then I told them to take another look at the oxybrita that the physician wanted him to be on and talk to him about maybe not having to get as many transfusions and all that stuff. So The last thing with this patient that we'll mention just to wrap up, because I know we've been going for like almost an hour now, but the last thing is the dreams, which I thought was really interesting. And I was kind of like racking my brain a little bit as he was telling me that, because there's no trauma, there was no PTSD, there's no anxiety at night, the dream, he can remember the dreams always, and like they just seem very vivid. And I was thinking about it for a little bit, and then I finally started asking about his CPAP. Because I asked him how often he's using it, is it comfortable? And he's like, I hate that thing. I use it for like 30 minutes maybe a night. And he goes, I haven't used it in like a week. I was like, okay. So we went from 30 minutes, I'm always using it, to 30 minutes a night, to I haven't used it in a week. Yeah. So that probably means 2 months. Yeah. And one of the things that can happen is if you're not getting enough oxygen to the brain while you're sleeping, or you're having these episodes of hypoxia, you're putting the brain under stress. You're not able to get to those more deep restorative, states of sleep. And so that when you are finally able to get into those states, either you're fiending almost like for that restorative sleep, and that's where those vivid dreams can come from, or the stress, itself from the hypoxic event in the middle of the night while you're sleeping is kind of precipitating those nightmare type vivid dreams. And so I double checked myself before I actually said that to the patients. I wanted to make sure that was accurate. I felt like that was true, but I needed to double check myself. And there's a lot of literature talking about inappropriate CPAP use, or like non-adherence to CPAP can cause nightmares and things. So I thought that was kind of interesting.
So many other benefits for this guy to use it too, related to cardiovascular health and stuff like that.
Yeah, so many things. So we had a long talk about CPAP and said if it doesn't fit right, then we need to get it reevaluated with sleep medicine and have them look at it. But there's definitely things you can do if you're not comfortable with the machine that you have. So lots and lots and lots to do with this patient. This will be like every 3 weeks until we can get this crap situated for like months now.
Wow.
So I thought this was a good one though. I like this. A lot of moving parts, if you will.
Very interesting.
Anything else with this one?
No, I think you covered it.
You guys will have to let us know if you guys found anything differently, or if you would do anything differently. We'd like to hear that. We're not really talking about this. Is more just my own head right now. But we got to come up with a way of doing some live cases too, so that people can like join us and stuff.
That'd be cool.
Maybe we'll brainstorm that. Yeah. But we'll get back to you guys when we come up with an idea. But if you do want more patient cases, let us know. Maybe we can move them to Patreon or something. If you do want more lecture style, content, then check out the Patreon. It's patreon.com/coreconsultrx. We at least once a week, if not more, we're uploading lectures and PowerPoint slides and practice questions and all kinds of stuff on there. So check that out if you haven't already. And for those of you who have subscribed, I really appreciate that. It helps us out a lot. And if you have any questions for Cole and myself, reach us in the emails or the social media handle that's in the show notes, or the text messaging, or the phone number you can text message us directly on. And any way you want to communicate, we will do our best to respond in a somewhat timely fashion. And we appreciate you guys listening as always. Thanks for the support. We'll see you guys in the next one. Have a good one.